which is that whole amount of money is donated to the Paris hospital. On his name, they established a foundation. The scientific essays, which has definitely revolutionized anti-HLA antibodies. Let us about to talk speaker, Dr. Sruthi Tapiawala, consultant nephrologist, Global Hospital, Mumbai.
So, good afternoon everyone. Now it's proper afternoon. So, good afternoon everyone. Now it's proper afternoon. And after the wonderful talk from all the speakers from the morning, my road is more clearer. I do not have to delve time on more of the technicalities. And I will take you through the clinical rigmarole which we go through day in and day out. Being a part of the lab and being a part of the clinical team, I get to see both the sides. So I'm the lucky person who can comment both the sides, and I will show you the clinico-pathological correlation in both. So we have all heard since morning that if we have preformed DSAs, we have an inferior outcome. There are multiple papers from the Paris transplant group and multiple papers from the Western countries which show that if you have pre-transplant antibodies, whether they are class 1 or class 2, your outcome of the allograft is inferior. These pre-transplant antibodies, preformed antibodies are formed because of sensitizing events, which was very nicely elucidated in the morning. These can go ahead and give you a lot of trouble during the time of transplantation, hence you need to identify them. Post-transplant, you can get de novo DSAs or you can get a memory response, and they can lead to acute events or they can lead to chronic events and lead to an allograft loss. This is a very important chart, especially for people who are learning transplant presently, like all of our students. You should know the timelines of what antibodies you want to look for at what times. When you are looking at a transplant patient, you would like to look at something known as current antibodies because that patient is present currently in front of you. You will also want to take a peek of what were the historic antibodies because these have gone nowhere. They are in your system, in your memory. Then you get a transplant done. You have to see what is happening to these antibodies which were there previously and whether anything new is formed. So this is where the crux of the matter lies, and if you identify them well, you can protect your patient from having adverse outcomes. And this is a paper from the Paris transplant group where they were very elegantly showing that you have no HLA antibodies, you do the best. You have HLA with DSAs, you will do inferior. You have only HLA antibodies, still you do inferior. You have an ABMR with DSAs, your outcome is not good. You have class 1 or class 2, irrespective, your outcome is inferior. And overall, if you have DSAs, you do poorly. So the goal of any assay today, we have been discussing CDC, we have been discussing flow. What do you want? You want to detect anti-HLA antibodies relevant to the clinical outcomes in transplant, i.e. HLA antibodies. The test should not detect IgM. If it detects IgM, then you should know how to monitor it. The test should detect even low titer antibodies because we have all seen that even low titer antibodies can cause adverse outcomes. The test should detect both class 1, class 2 antibodies. This is important because sometimes when you have a cell-based assay like a CDC or a flow, sometimes the viability of the cells comes in effect and it gives you false outcomes. And this has been the evolution of the assays right from 1960 till 2010 when the solid phase assays were innovated. And this has all been done in pursuit of excellence. Why? Because we want a good graft outcome. In our resource poor country, this is even more important because we do not want our patients to be on dialysis. We do not want our patients who have gone through transplants to lose their allograft because we do not have enough donors. We do not have enough cadaver transplantations. We are basically a living donor program. So we have to be careful with our allografts. So these are the differences between the HLA antibodies which are identified. So if you see the CDC cross-match, you will have HLA antibodies identified. Non-HLA sometimes are identified. Now there was a question from the past talk where someone was asking that what is the significance of these non-HLAs when they are detected or they are not detected. Remember one thing, CDC cross-match is looking at lymphocyte cross-match. You are not looking at endothelial cross-match. And if you look at the non-HLA antibodies which are relevant to transplantation, they are anti-endothelial antibodies, AT1 receptor antibodies, MICA. These will never come positive in a CDC cross-match because they do not activate a complement. So stop looking for relevant non-HLA antibodies in a CDC or a fluke. IgM detected in CDC, yes. Low titer non-complement antibodies detected by CDC, no. Antibody titers detected moderate to high. 8G CDC, extended CDCs, more sensitive. You have all heard very beautifully by Dr. Rajeshwari. Flow cytometry cross-match, low antibody titers detected. Dr. Handu has very beautifully shown what one can do with a flow cytometer, which is not as expensive. Cytotoxicity with flow cytometry also has been shown. And last is the solid phase assays, where you have a little more sensitive platform. But if you merge the flow with the solid phase, using the solid phase, you will get a good outcome. So what are the solid phase assays we have today, and what does it mean? Purified HLA molecules are immobilized on the surface of solid surfaces, higher sensitivity than the CDC based assays. So one is the ELISA platform. It was known as T-screen previously. And this was the platform used till 2010 to try and get an idea about the panel reactive antibodies and the identification of antibodies. Then came the beads with flow cytometry. So we have two options for identifying the HLA antibodies. One is the flow cytometry based beads, which are made of latex, and one is the Luminex solid phase assays, which is the polystyrene beads. Like Dr. Handu says, the flow cytometry can also be used, but it has to be standardized in your individual lab. So do it, but do it in a systematic manner. These are all used for HLA antibody screening and identification of donor-specific antibodies. This has also been explained very nicely. Cells versus beads. Cells have a lot of interferences, whereas beads are factory made and they will tell you what is the antigen on it, what is the density of it. So you don't have any interferences of non-HLAs or substances which you don't want. Now I'll just go through the different beads which are available. So there is something known as a mixed screen assay available both for flow and for the Luminex platforms. And the solid phase testing type, one is a low resolution. Now for my nephrology colleagues, I always tell them that a low resolution is as simple as yes or no. When I want to look for a CMV viremia or something in a patient I'm suspecting, what will I do? I will do a CMV qualitative assay. Why? I want to say a yes or a no. If it is positive, I will go for a viral load. This is the analogy I try to teach to students, that if you want to screen that there is HLA antibodies, yes or no, just do a screen. That is not expensive. Do a screen. If it is positive, then you go to the higher level to understand what are those antibodies. So these beads are low resolution, and they will have two types of beads. They will have class 1 beads, class 2 beads, and class 2 and class 1 will have individually class 1 HLA antigens attached to it and class 2 attached to it respectively. And they will give you a yes or a no. I will tell you the disadvantages of these in some time. So what is a PRA? A measure of preformed antibodies in a potential recipient, HLA and non-HLA antigens, against a panel of antigens from multiple donor cells from the population. So previously the PRA was done by CDC method, but now you can do it by solid phase method. So this is not to a specific donor, this is to a population. Percentage PRA, this is a different type of a kit we have, where it is a low resolution, yes or no. Intermediate resolution, where PRA sometimes will give you specificities. The beads show me specificities. I can calculate the percentage by number of positive beads / divided by the total number of beads multiplied by 100. This gives me the calculated PRA. So a bead is like a pseudo cell, and there are multiple antigens which are attached, class 1 and class 2, two different set of beads. It is used to define the degree of sensitization. Say you say 10%, 20%, 30%. This is not used much in India because we are not using this for allocation system. But if we are using it for allocation, we are using it as PRA positive, negative, give 1 mark more on the allocation system. Then comes the last high resolution, which is the solid phase testing for single antigen bead assay. So the single antigen bead assay is a high resolution. It will have inert beads, polystyrene beads, which will have only one specificity of an antigen attached to it in a particular density. And these are factory made beads, and it will be a cocktail of beads which is available for class 1 and class 2 separately. So one bead will have only one antigen, one type of specificity antigen attached to it. Now that brings me to the virtual cross-match technique, which is important for everyone to understand. There was the last session, someone was talking about the eluted antigens. So the eluted antigens is a lysate cross-match. That and this should not be mixed together. That question I understood because someone was trying to ask whether the antigens, when they are eluted, will they stick to the beads. That is a different story altogether, because that is not what a DSA analysis means. That is a different type of an analysis. I will show you 2 slides on that just to clear the myth. So what does a virtual cross-match refer to? It is comparison of anti-HLA antibodies of the recipient as defined by either Luminex or by the flow cytometer with the HLA typing of the donor. It is virtual because you are not doing a physical cross-match. What is a physical cross-match? CDC cross-match, flow cross-matches are known as PXMs, physical cross-matches. If there is a donor-specific antibody present, this would represent a positive virtual cross-match. Antibodies are defined against HLA class 1 and class 2. Now I am just showing an example of a virtual cross-match, more for students. I am sure the people are practicing this. So if you look at this recipient, he or she has HLA antibodies to A33, A68, B4403. If you look at donor 1, there is no HLA antigen which is matching with the antibody profile. There is no A33 in the donor, there is no A68 in the donor, there is no B44 in the donor. So this virtual cross-match is negative. If you look at the donor 2, there is a 3301 on the donor A. There is a 4403 on the donor at the B locus. So here the virtual cross-match is positive. Now let's look at this in a different way. I want to show you what a Craig association is. So if you look at this, the donor 1 does not have A33, A68, B07, 02 or B47. So here the virtual looks to be negative. Even in donor 2, the virtual apparently looks to be negative. So HLA B5201, 2705. Apparently if you see this, there is no match. But B2705, B702, B47 are from the cross-reactive group and they are from the same family. So if one antibody is present from that family, all family members will be antigenic to that patient. So what is a Craig? Historically, as sera became more precise, it was clear that certain antigens actually had serologically distinct splits. If exposed to A25, for example, and you make a unique A25, they will react to only A25. But if exposed to A25 and you make an antibody to the epitope, which Dr. Firoz will again say, that is shared, you will look like you are making A25, 26, 34, 66, and they do matter. Because these cross-reactive epitope groups will have the similar amino acid residue and they will have a VXN positive. Now, other thing which you can do with solid phase assays, like you can do with a flow solid phase assay or a Luminex solid phase assays, you can do a complement binding assay. As we know, as we go ahead, we are realizing that not all HLA antibodies may be pathogenic. Only the ones which are activating the complement will be pathogenic. So this was a beautiful paper brought out in NGM where they identified that if you have a complement binding antibody, then it is more pathogenic and your graft survival is inferior. Both the vendors who have the Luminex beads and the flow beads, which are from one of the companies, have a complement assay which can be added to it, and we can actually give you identification of which of the donor specific antibodies are complement binding and which are not. This will help you streamline even further. Why is it not available so freely? Flow C4D is available very freely, But this is not available because it is marked as research only use. So if I have to use it for day-to-day practice, I have to sign an agreement saying that I will not use it for day-to-day practice and this is only for research. So the labs are stuck and we are trying to get around it, but I am sure over time this will happen. Now the MFIs and implications. So you have a cumulative MFI or you have a single MFI, but as your MFI goes up, it is known that your risk of rejection might increase. Again, this paper is there are multiple papers, but you can dissect it out any way you want. They have to be complement fixing, they have to be of a particular ITT class, the lab MFIs may not be the same comparative to different MFIs of different labs. So, higher the MFI, you will have a higher chance of having an event. But again, like Dr. Handu said, there are many denatured antibodies, beads which are available where you will have to identify, or the lab person, like Dr. Handu said, the man behind the machine is more important. I need to identify whether this is a really high MFI or this is a falsely high MFI which I am seeing, and these are denatured antibodies and I need to get rid of them. Now comes the elute part. The lysate crossmatch or the DSA crossmatch or the Luminex crossmatch. These are the three names it goes by, and it is very avidly picked up by all the clinical practitioners. And this is test beads coated with antibodies that capture the HLA antigens incubated with the lysate prepared from the donor lymphocytes. And then these are tagged and these are run on the Luminex machine, and it is known as a DSA crossmatch. In fact, there are company people rallying around saying that the donor is made immortal because you can save the lysate. Now, I'll show you some cases. 31-year-old lady, donor brother, sensitization history, previous transplant, multiple blood transfusions. Lysate crossmatch has been given negative, class 1 and class 2. CDC crossmatch comes positive. Flow cytometry crossmatch comes T and B cell positive. What do you make out of this? You cannot neglect the physical cross matches. Then a PR antibody screen is done, which is both positive, and there are DSAs with more than 10,000 MFIs. So here you can see clearly that the lysate crossmatch was false negative. Case 2, non-sensitized. Class 1 turns positive in the lysate DSA Luminex crossmatch. CDC crossmatch negative, T cell B cell flow negative, PR antibody screen negative, hence single antigen bead not done. So these are only two of the many cases which come to me in a confusion that, oh, this is positive and that is negative, now what do I do? Should I proceed for transplant or no? So there are multiple studies which have now been released from our country and only few papers from abroad, because Western countries and Europe does not use this test, because it was not validated for use, and there are papers which say that if it is used, then you have to use it with one of the other solid phase assays like a PRA screen or an SAB to see that the report is really positive or negative. So you cannot use it as a standalone test. Now if you cannot use this solid phase assay as a standalone test, why will you do this ever? So you have to understand that this detects complement fixing and non-complement. There are non-availability of monoclonal antibodies to CDP and DQ, and that is why the CDP DQ antibodies will never be picked up. False positive results due to non-specific binding of antibodies to cryptic antigens may occur. So this test is fraught with fallacies. So you have to be careful when you are using it to deny a transplant or take a transplant ahead. And if you have to use this and a physical cross match and then use another solid phase assay, why do this? Now I'll go to some cases, real life cases which we are handling. 28-year-old male suffering from CKD, hypertensive, maintained on hemodialysis, working up for a living donor transplant, donor being his father. He has history of 2 units of blood transfusion. This is what we have: CDC, auto, T cell, B cell negative, allo, T cell negative. Now this is all run in my lab, so I have all the dilutions and all the AHG and everything done, so I am not mentioning. This is an extended cross match with AHG with all the dilutions and the T cell, B cell, auto, allo done. Allo B cell turns out to be positive. Flow cytometry cross match, allo B cell again positive. Now we are looking at the HLA typing of the donor and the recipient, and if you see, the ones in white are mismatched and the HLA match is a single haplotype match 8/16. We did the PRA screen, class 1, class 2 negative. We also did an SAB screen. Why did we do the SAB, single antigen bead assay? Because I was very much worried that why would a B cell and a B cell in CDC and a B cell in flow be positive? And I wanted to ensure that there are no HLA antibodies which is being missed. So, father to son, single haplotype match, we have positive physical cross matches, PRA screen negative. Conclusion, physical cross matches might be false positive here, but a caveat. Have we looked at the representation of the donor on the beads which we have analyzed? And yes, we looked, and this turned out to be a false positive cross match. Among so many cross matches which always come properly true negative or true positive, this was one thing where we looked again and again to see if there was anything causing it positive. And other part, sometimes some people do a CDC cross match first, they may do a single antigen bead assay later. So if you have a gap of more than a month, I would say repeat it from the same serum, because the antibodies may wax and wane. So we repeated that also. So this finally turned out to be a false positive. False positive physical cross matches may happen. In CDCs, not all lymphocytotoxic antibodies will be donor specific. They might be non-HLAs which are non-relevant to transplant. Some may display autoreactivity, we had taken care of that. Absence of donor antigen representation on the bead panel, we took care of that. Cell viability, especially B cells, is an issue, that was also taken care. False positive flow cross matches, it is a very sensitive assay, you need to standardize it very well. Flow is not an easy test. Once set up, it is very good, but setting it up, standardizing it is important. Detection of low titer and non-complement fixing antibodies may have little or no clinical relevance. Monoclonal antibodies like Ritux can cause a false positive. Our patient had not received Ritux. He was an ABO compatible and a single haplotype match. Case 4, 37-year-old lady suffering from CKD and CGN, worked up for living donor transplant. Donor is her mother. History of blood transfusions and 3 pregnancies. These are the mismatches. The HLA match is 9/16. We do all the A, B, C, D, R, D, P, D, Q. Hence you are seeing all. There is a thorough workup done for every transplant so that later on we don't have to go back and think what did we miss. CDC cross match is negative. Should we look further? So this is the basic testing which each and every one of you must be doing. And at the most I can say discounting that ABDR must be happening. So this is a little more of the test. Being a mother, being a donor, should you look ahead? Yes, you should look ahead. She has sensitization history. You should not miss out on antibodies. So we did a PRA screen which we do for all our patients. Class 2 turned out to be positive. Now we were like, okay, she's sensitized, maybe she has antibodies against her husband because she's had multiple pregnancies and the donor is mother. We might be able to get away with it. So we did the single antigen bead assay. Now this is a complete list, but what are the donor specific antibodies here? DR beta 1 1502 came to be donor specific and HLA DQ came to be donor specific. So my virtual cross match came to be positive. And the summary, if I see later on, because I saw this that the CDC was negative and the MFI was less than 15,000, I did a flow cytometric cross match which the primary physician had not asked, and lo and behold, the allo B cell turned out to be positive for the flow cross match. So we had a VXM positive and the flow cross match positive. So if you do only a CDC and you do only an HLA typing, you might not be on the right track. One solid phase assay with one physical cross match should be done at the minimum. VG, this is an old patient of mine, 28-year-old male who underwent a cadaver transplant in July 2013. This was done at Chennai and he did not have any donor details. He underwent a second living donor ABO incompatible renal transplant with donor being his mother in May 2019. He had history of blood transfusion in September 2018. And this was the HLA profile. That time we did not have a DP and DQ done. I did not have a lab at that time and this was not very freely available. December 2022 he presented with a raised creatinine and proteinuria. Biopsy was showing ABMR. Now what was his HLA antibody status post-transplant? So we were doing the post-transplant single antigen bead assay monitoring every year, because I had told him that we should be monitoring you 6 monthly to yearly, and if there is an event. PRA screen turned out to be weekly positive in 2021 August. You see, in December 2022 he has presented with an event, but here there was something which was positive. Hence I flexed to doing a single antigen bead assay, and there an A26 was weak positive. It was only 1100, I remember it correctly. And I was like, I'm not going to reduce his immunosuppression, I'm going to keep it as it is, even if it's a weak antibody. Again, we have repeated at the time when he presented with a raised creatinine, but there were no DSAs, no class 1, no class 2, and I had done a biopsy parallel, and it showed a bad chronic antibody mediated rejection, and the histopathologist actually told me that, Dr. Shruti, there's nothing to be done about this patient. You can't repair this kidney. So I was surprised. So that means that, you have to monitor the HLA antibodies, but you have to be very sure that sometimes these antibodies, 30% of the times as per literature, may be in the graft at the site of action and may be missed in the peripheral blood. So monitoring is important, but at the same time, the clinical relevance has to be noted. This patient was treated with Plex, IVIG, optimization of immunosuppression, and then we repeated one more in May. In May, I can see a C16 DSA, again very low titer. So he had very low titer antibodies which must have attacked the allograft, and this patient is now planning a third transplant. Third transplant, his sister has come ahead. I was hoping that it would turn out to be a full match in the siblings, but no. She's a single haplotype match with her mother, and of course the same antigens going back into the patient. I have said we are not taking you as a donor unless I get an acceptable mismatch swap pair for you. SG, this is another story of a 14-year-old boy who stopped his immunosuppression during the COVID time, and he landed up with a chronic antibody mediated rejection, and a second transplant is contemplated. Father and paternal aunt have come ahead. The first donor was his mother. CDC and flow both are positive, and PRA screen turned out to be class 2 negative, class 2 positive, and we have a DSA against DR beta 40101, and this case highlights the importance of identifying DR beta 3, 4, 5 HLA typing also in cases where indicated. So look at the antibody profile and accordingly do an HLA typing. So both these patients have landed up with a transplant glomerulopathy, and there are elegant studies which show that, de novo DSAs, when people have chronic antibody mediated rejection, they have an antibody profile predated to at least 6 months before all this pathogenesis starts. So it is imperative that we monitor these patients. And this chart has been shown to you before, so I will not repeat it, but I would only want to say that we have to optimize at this level. Once it goes to C4D deposition, our tissue injury has started. So we have to be alert even before the C4D starts depositing. Now I go to the cadaver transplant realm. 26-year-old male, CGN on MHD, 8 years. Listed for deceased donor transplant, history of 8 blood transfusions. Organ allocation was done based on CDC crossmatch, which was negative. CIT was 4.5 hours. At unclamping, kidney was pink and turgid, but there was no urine output. Doppler was showing an RI of 0.8, no diastolic flow, query ATN. Could it be rejection? A PRA screen which was dated at the time of the listing was class 1 and class 2 positive. Now the family was counseled at the time of transplant that you have a class 1, class 2 positive, you might have a DSA, we should do an SAB and a donor HLA, but they were short of funds. They were counseled, they were explained the risks that this might be a DSA and you might end up with a rejection. But they wanted to go ahead. They in fact signed a very high consent form and went ahead. Biopsy done was showing ABMR. The patient was put on Plex, IVIG, all the immunosuppression, discharged after giving a retux. A donor HLA was done on day 2 post-transplant in evaluation of the non-function of the renal allograft, and DSAs were found to DR7, DR beta flow, DQ0301, DP beta 1, 0201. Class 1 did not have DSAs. Patient has settled at a creatinine of 2.6 but has a proteinuria of 6 grams. And this is the monitoring of the DSAs. We have 2 single antigen bead assays done from the time of transplant. And if you see, the green is the antibody levels at the time of transplant, and the blue bars are the antibody levels as of last week. And to mind you, this trend has been done with a single run, because run to run the MFIs may change. So I did not want to get that hampered, so this is what. But nevertheless, the patient already has allograft dysfunction. So important, in case of deceased donor transplants, you should do a virtual cross match in the middle of the night. We do it for all the patients, barring a few cases where they are not agreeable to it for financial reasons. If you do not have an HLA, say you have done a transplant long back, what will you do? So we do something known as trend analysis, where you can do only a PRA screen, because you don't know which is a donor specific HLA, and you want to see what is the antibody profile in the body, and you can see that this is a patient who got a transplant done elsewhere. It was an altruistic donor and he did not have any details of the donor. So he came to us with a rejection. We did an antibody profile, and you can see that the blue line was at the time when he came with an antibody mediated rejection, and after that we have been monitoring it, and the antibody levels have been below 5,000. Mrs. AS, this is a case from Hyderabad, I should say. 52-year-old patient, just last 2-3 slides. 52-year-old female suffering from CKD, hypertensive, and had history of 4 pregnancies and 3 abortions. She did not give history of blood transfusions. Her husband was the potential donor. A lysate cross match was done, which was class 1 negative, class 2 positive. Flow cross match done was negative. This was the profile which came to me. The single antigen bead assay class 2 was positive, but lo and behold, if you look at the single antigen bead assay, the DR, everything was positive. DP, DQ, everything was negative. Now DR, I can understand only DR antibodies, but there were antibodies against her own antigens also. And that antigen was matching with her husband. And that was called as a DSA, which is not fair, because if you have autoantigens, then you have to first look at your run and identify if there is anything which you can do to make the run pure. We repeated all the things, and all the things means we did not repeat the HLA typing, but we repeated a SAB class 1, class 2 flow cross match. And the B cell flow cross match after diluting to 1 in 8 has turned positive. We do 1 in 2, 1 in 4 and 1 in 8 dilutions for all our flows and CDCs, and the prozone effect was brought into picture, and there was a donor specificity to C14. Remember, in the previous the SAB1 was negative. And we found that there are DR beta 1 14 at antigenic level, DR donor specific allele level, DR 1404 specific bead is not available in the SAB kit. So you have to always look at what is not represented and what might be causing it. So now these 3 cases you are seeing, they are stuck with a sensitized status and not knowing what to do. Do you desensitize? No, because desensitize itself is a journey ahead, where you will have to keep monitoring the patient with cross matches, and you will have to monitor the patient with the antibodies. You will have to over immunosuppress. Money is not even counted over here. Or you just find a nice donor where you do not have any donor antigens which have antibodies in that recipient. So that is what brings me to an acceptable mismatch. This is a big application of Luminex or a flow solid phase assay, which can be done in today's world to I should say smartly navigate a sensitized patient towards a low risk transplant. So what is an acceptable mismatch? So if you have a patient where you have an HLA typing, you have antibodies identified to DR7, 9, 53, DQ2, and you have a potential donor with a complete HLA mismatch. But if you look at the DR, there is DR8, 16, DQ4, 5. There is no antigen against which this patient has an antibody. So this patient is an HLA compatible donor to this sensitized patient. That is what means an acceptable mismatch. And we actually have a registry and a software where we can form pairs and we can give a low immunological risk transplants, and we are trying to get many centers merge into this so that more and more patients, because we are looking at more sensitized patients in today's world. For the child SG, I have found a 4-way match, and for the other 2 patients, I am still searching for a match. So what are the applications today of a Luminex platform or a solid phase assay? I will not say Luminex platform, solid phase assay, because you can do it in various ways. You identify the presence of HLA antibodies, do intermediate high resolution typing of donors and recipients, identify the specificity, quantify them. You can monitor them. You can monitor for the appearance of new antibodies. You can pick up the memory antibodies. For example, we store all the serum from whatever time the lab started, and I might have 5 to 6 years worth data of all the sera, and I can analyze anything with any technology I want. Identify whether complement binding or no. Identify non-HLA antibodies relevant to that organ. More for non-kidney in this. But you have ELISA assays which can identify 81 and all that. But you have kits on the solid phase assays also. Someone might think that virtual cross-match is the way to go, but no. There is a lot of, I'm going to skip a few slides. I'm going to come to the last slide. So the thresholds we have to do. The man behind the machine is important, not the machine. Machine can have artificial intelligence, but you have your brain to tell you what it's doing. So threshold used to define strong, moderate, weak antibodies have to be checked. Thresholds vary from one lab to other, and there is no good agreement between the thresholds. Someone might give 800, someone might give 1000. A virtual cross-match may not always predict whether it is true positive or true negative, because antibodies which are very low can cause a positive actual virtual cross-match. Antibodies wax and wane. What you may have 3 months ago may not be there in the serum today. So we can only comment on the antibodies on the serum that we have, not on a serum prior to the patient ever coming in front of us. So VXM should be always interpreted along with the physical cross-match also, and it should be viewed with historical samples. And I always tell people that cumulative antibody list is important, not the list today in front of you. You cannot say that today you have these antibodies, wait for 6 months, they'll go away, then I'll transplant. No, your memory will come back. So the two algorithms which I use for clinical practice, whether you have a living donor or a deceased donor transplant, at workup, I do the HLA A, B, C, DR, DP, DQ intermediate resolution. Why? Because your single antigen bead assay is of intermediate resolution. If you do a low resolution, you will not go to the allele level. Do a PRA screening along with it. And at that same time, if you have a living donor, do a CDC cross-match and a flow. I do both for now, but you can always go to only flow and PRA screen if you have a good flow setup and it is well standardized. CDC cross-match, if you are doing, I will sum up for Dr. Rajeshwari also that do it in a thorough method. That is still gold. So don't say that my hospital does not have flow, main kya karu. Use the CDC to the best, do a PRA. You have to do the best in what you have. PRA screen, negative, you do a screen every 3 months till the patient gets organ. At the time of transplant, AHG enhanced CDC cross-match, flow cross-match and a donor typing. All these negative go for transplant. If you have something positive, flex to a single antigen bead assay on a flow or on a Luminex platform. Do the enhancement studies, do a proper cross-match. If you have positive cross-matches, you may have to contraindicate the transplant. Sometimes if you have a CDC and a flow negative and only a VXM positive, you might even thinking of desensitizing a patient, because these are the patients who might do well with desensitization, versus you may have to think of a living donor paired exchange. And how do you surveil the graph? There are no recommendations anywhere, but what do? Every 6 months to 1 year, we monitor the patients. We tell the patients uphand that your BKV viremia PRA has to be screened 6 monthly, because we want to save you against immune events and infective events, and that is where I am. Thank you. Sorry for overshooting.
Thank you, Dr. Shruthi. It was an excellent talk. And I'll take just 2 questions. One question. Only one question. Okay. 1 minute short question.
Flow DSA.
For Dr. Shruthi.
So we are not getting many PRA requests. So actually,
but flow DSA is running a flow cytometry cross match with your beads, right?
Yeah.
So you have to validate it with your PRA screen and your single antigen. If it is validating well, I think you can use it. And if you keep a PRA screen, see, I did not mention, but PRA screen sometimes 50% of the alleles are still not represented, but at least all the antigens are covered.
Yeah,
So I find it as a very good parameter to compare it. So where I find that the PRA is positive, I will see the SAB turning positive. Where I see a PRA negative, SAB does turn out negative, and many times I use multiple platforms to run the patient serum to understand if I'm missing something. Say if I give a CDC crossmatch positive, you may not know, but I may have informally run a PRA for you, so that my report is not false.
Yeah.
Is it a CPRA or a NOVO?
CPRA is a costly affair because that kit is costlier than the normal PRA screen. A normal PRA screen will cost a patient nothing more than 6,000 to 7,000.
Thank you, Shruti and the chairperson. I think we should conclude this session, and we have two more sessions before we break for the